Already it's 4:09. Yeah, I think it's a good afternoon to all. We have practicing pediatricians and we have postgraduates. It's good to have these kind of meetings because I really like these case-based discussions, rather than talking on particular topic, talking like hours and hours. Nowadays you could easily Google and then you could read, and you don't need to kind of attend the physical meetings or webinars. So nowadays, if you really want to get the information, now we have digital media is there, social media is there. You could get plenty of information from all these things. But this case-based discussions, you don't get it anywhere. This is all based on your based on our clinical and practical experience, how we have dealt the cases, different problems and different diseases, and how we are managed. So we thought, this kind of CBDs, in other words, case-based discussions would be useful to the, the practice pediatricians and also the PGs. So this CBDs is going to be, we are going to organize once in every fortnight. That would be on alternate Thursdays, between 5 and 6 p.m. So all of you, please come, on time, like 5 o'clock, so that we'll start promptly, and then we'll end this session by 6 p.m. so that we could do the other works and after 6 o'clock. So what we thought was that this would be the learning curve to all the PGs and some of the practicing pediatricians. And we will try our level best to keep all of you to interact with us, and we'll try to make it interesting and informative. So what you could do is when the speaker is talking on something, you please mute. And when you want to interact, you unmute and then talk and then mute again. So please do that. So when you're not talking, please mute yourself. And when you're talking, unmute and then talk and then mute again. So, so we have about 817 people actually registered, joined in our group. I must say that it's a definitely phenomenal response, from all of you. So today we have speaker Dr. Raymond. He is the consultant pediatric intensivist from Andhra Hospitals, and he is also academic director of Andhra Hospitals, Department of Pediatrics. So he's trained in JIPMA. Can you mute, please? Please, can you mute?
So unmute
Okay. So it's Dr. Raymond. He's basically trained in JIPMA, and he did his fellowship in pediatric intensive care from Child Trust Hospital, Chennai. So he's an experienced intensivist, and as most of you already know about Dr. Raymond, is a very proactive and a very dynamic pediatrician. So I think without wasting much time, we would straight away go into the case-based discussion. So all over to Dr. Raymond. Thank you, one and all.
Thank you, sir. Thank you for the kind introduction. So without wasting time, I will share my screen. I'm audible?
Yes.
Does my screen visible, sir?
Hello?
Does my screen visible?
Yeah, it's visible.
Slides are moving?
Moving. Yeah.
So we'll take this discussion in a case scenario based fashion, like a case based discussion. And I'll be going through a case scenario, and meanwhile I'll pause for a few questions. And who want to answer, you can unmute yourself and answer one at a time. Don't unmute two people at a time. So we are not for having a disturbance in between. So it will be simple case scenarios only, but I think we need to, PGS has to try to answer few of questions. So this is about 1-year-old male child. He was taken to a nearby hospital with the complaints of fever for 7 days. And he also had 2 episodes of GTCS seizures in the home, each one lasting about 5 to 10 minutes, and he was not regained consciousness in between. So on provoking, they also revealed that child had multiple episodes of non-venous vomiting for the past 2 days. So with this history, child was taken to the hospital. And attended to local hospital, this is the initial assessment. So he was unconscious and actually seizing, and breathing wise he has increased work of breathing, and his peripheries are pale. So what is the interpretation based on this initial assessment, and what the intervention we have to plan here? Anyone? This is simple scenario only, PGs. Or if you want, you can put in the chat box as well. Yeah, few of them answer is like life-threatening, unstable. Correct. What is the intervention we have to plan here? We are at the step of initial assessment, not at the primary assessment.
Start oxygen, sir.
Yes, correct. And child is also actively seizing.
Left lateral position and the secure IV line.
Yes, correct. So before we secure IV line, can we progress to primary assessment? The same thing, it's unstable life-threatening condition, start on oxygen, and we can ask for IV access. Meanwhile, we can move to primary assessment. This is the primary assessment. So what is your interpretation from this primary assessment? So airway is not maintainable. So breathing was tachypneic as there is a stridor. The saturation is low on room air, which are improved with oxygen. And the circulation, tachycardia was there, low volume pulses. CRT is 4 seconds, cold peripherals, but BP is on higher side, 120/80. Disability wise, GCS is low, 10/15, and he was having active GTCS. And an exporter, he had a temperature of 1 or 2 degrees Fahrenheit. Is there anything we're missing here in this triangle, or all the things are there here? And what is your assessment and what you want to do now? Physiological classification. And one more thing is, what is the reason for this unmaintainable airway in this child? And the child had a stridor also is there. Reason for unmaintainable airway with unstridor.
CNS cause, sir.
Yeah, CNS cause due to what? How it can cause?
4 days, yes, child is having seizures. So,
Okay. So what you're expecting in this child? Why is this CNS child we know? Food diseases we know. So how it can cause this stridor and unmaintainable airway? Because if you know that only, you can manage this child. So previously, some person told to put in the recovery position, left lateral position. So why that is needed? The main culprit here is the pooling of secretions and your tongue fall. You don't have,
Aspiration.
Fallback of tongue.
don't have control over the tongue. So if you put in left lateral position, some of the secretion can come out and your tongue can be moved out from the airway. And the most important reason what we have to do is you need to do suction here. So we'll move on to evaluate, identify, intervene algorithm. So what we identified here is status and respiratory distress. Is it in shock, compensated shock? How many of you agree it is compensated shock?
BP is normal. BP is normal.
BP is high actually. Yeah, 100% correct point. And cold peripheries and tachycardia alone cannot tell it is a shock. And when BP is on the higher side, unless you have some renal problem causing hypertension, which is causing this obstructive shock, most likely it will be to do peripheral temperature, having temperature, fever, so it can have peripheral failure. So we need to assess this carefully. So for airway, we need to airway protective measures. One is positioning the child, opening the airway, doing suction, supplement oxygen. Shock, I'm not convinced of shock in this child, so we need to watch the vitals carefully. He can progress to shock as well. And for the cerebral dysfunction part, seizures, we need to give injection midazolam, we secure the IV line. And most important, we have to check the glucose. It was not mentioned in the slide deliberately. But checking glucose for this child is very most important. And you need to control the temperature aggressively. So don't stop there at the midazolam. You have to move on to the exposure also. So you need to control the temperature. It will be detrimental for a actually seizing child. So this is the algorithm which was given by our American Epilepsy Society in 2016. And with the initial stabilization phase, what we've done, then we have to move on to the termination of seizure. So what is the first choice of seizure when you are able to secure IV line is intravenous lorazepam. They are not giving intravenous midazolam. The most probably maybe the more respiratory depression with the midazolam. So they are moving away from the intravenous midazolam. Now they recommend intravenous lorazepam. And second choice is intravenous diazepam. And if you're not able to secure IV line or IO access, then your first choice is intramuscular midazolam. It's not intranasal midazolam, it is intramuscular midazolam. And then our second choice is intranasal midazolam, where it is available. No midaspirates are available, so you can go for midazolam nasal spray, and you can give buccal midazolam as well. And if it's not available in peripheral community settings, you can try rectal diazepam then. So I think I'm clear on this. And the second, if you're not able to get terminated with this intravenous midazolam or lorazepam, then you can try after 5 minutes, you can give second dose. Even after that, you're not able to terminate the seizure, then you can go for the second line therapy. So the second line therapy is your injectable agents, loading agents. It could be fosphenytoin, or it could be valproic acid, it could be levetiracetam. So the doses that are recommended now is the highest doses possible. So previously we are going to start the lowest dose and we go up on reloading. But they are not giving that now, because you need to terminate the seizure as early as possible.
As early as possible.
So don't delay. You just go for the hit it hardly. Just hit it hardly with highest doses, recommended doses, and it's safe. There are a lot of studies showing that highest dose is safe to give in the emergency setting. So try to give levetiracetam at the highest dose is 60 mg per kg loading, maximum is 4.5 grams, and valproic acid 40. And fosphenytoin, it is a 20 mg of phenytoin equivalent that recommends to you 30 mg per kg of fosphenytoin. So these are the 3 drugs recommended, and there's no efficacy difference between 3 drugs. You can choose one among them on your comfortability basis. If you are very versatile with phenytoin, you can go for phenytoin. But the problem is phenytoin you have to do slowly. But levetiracetam you can do fastly. So now majority of the units, tertiary care units, are moving towards levetiracetam than phenytoin. So for my choice, first choice is levetiracetam here, and the second choice is fosphenytoin. For further course in the ER, seizure was terminated with midazolam. We loaded the phenytoin there. And what are the DDs you are suspecting here? And anything you want to look for the examination of this child, and work out what you have to plan, and what the further management of this child. So we have a seizure, fever with seizure child. We give midazolam. We terminated the seizure. We loaded the phenytoin. And so next movement, next one move on to. So what are the DDs? And anything we have to look for next examination, workup. Yeah, someone correctly answered it's a febrile encephalopathy. So what could be the DDs for febrile encephalopathy? So meningitis is one possibility. In examination, what are to look for?
Pupils.
Yeah, good, very good. Pupils.
Reflexes.
Before the reflexes, because already we studied the medulla. You're suspecting DDs is febrile encephalopathy. One of the DD febrile encephalopathy is meningitis.
Meningitis. Encephalitis.
Encephalitis, good. And it could be simple febrile status.
Atypical fever.
Simple febrile status, atypical, exactly. So my DD here is CNS infection. It could be meningitis, encephalitis. It's a simple febrile status. All the recent entities what we are dealing is files. And I have to look for meningeal signs, any focal deficits, pupils exactly, and fundus, and organomegaly. Fundus is mainly for ACP. So organomegaly mainly to look for any etiology. If you have any hepatosplenomegaly,
Infectious etiology.
yeah, infectious etiology like malaria, strep like thing. Then I can plan for workup when putting IVLN. I can go for CBC, CRP, electrolytes, ABG, and blood culture because I am suspecting meningitis in this child. And I can wait for neuroimaging at this situation because the child is terminated.
Unstable.
Yeah. Then if sensorium is not improvising, then I can go for neuroimaging. So antibiotics of choice when you're suspecting meningitis. Empirical choice of antibiotics. Usually we go with ceftriaxone and vancomycin. And if you suspect encephalitis, then you can try add an acyclovir. And if you are suspecting any focal, any organomegaly, and you are suspecting strep typhus, then you can add doxycycline. If you have an organomegaly thrombocytopenia investigations, then you can go for doxycycline as well. These are usual spectrum of antibiotics you give and suspect acute serious infection when you don't know what the it could be. It could be meningoencephalitis or encephalitis unless child woken up.
ఇలా అడ్డంగా పెట్టాం కదా సరే
Please, can you note, please? Yeah, Revant, come a bit closer, bit more volume if possible.
Yes, sir. So with this scenario, can we proceed to LP now? Because one of our DDs is meningitis and encephalitis. So when we can finish off LP right now? And if the answer is no, then what could be the reasons for telling no? Yeah, some of them answered it's no, and the most probably they're telling is
unstable.
Yeah, then we'll see what are the contraindications for LP in a child. So these are the risk factors for cerebral herniation, which was given by our American Family Physician Association in 2017 issued. Its main thing is altered mental status. So the first and foremost thing, if any child is in altered mental status, could be the post-ictal also. We don't know. So you have to be very careful when you're attempting lumbar puncture. Or if you identify any focal neural deficit or any history of previous CNS disease, like any focal ixals, you should not attempt in them. Our child has a sense of rigid ACP like bradycardia and overt rigid ACP, any herniation features with hypertension. And if you notice a papilledema and the child is having respiratory abnormalities where you want to waiting for intubating this child, and active seizure or seizure which was got terminated just prior like half an hour to here they give like up to 1 week also. But usually we take it seizure at least we wait for at least if the child is unstable and not maintained, sensation is not normal. Usually we don't attempt it for more than 24 hours. Usually we wait for 24 hours. Even if the seizure is not there for 24 hours. If sensorium is not normal, we will not do the LP. But if sensorium is completely normal and seizure is terminated, then we can attempt after 2 to 3 hours. Is it safe to wait for LP rather than going for LP to confirm your diagnosis? If you're giving antibiotics or treating as a meningitis, it's not a harmful, but retaining antibiotics without withholding antibiotics to confirm a diagnosis of meningitis sometimes can be harmful. So please follow the guidelines what they given. So further course, after a few hours, change has completely normalized. And an examination, we noticed that meningeal signs, and they treated the child as pyogenic meningitis, ceftriaxone, vancomycin, along with the dexamethasone. And LP was done after 24 hours. And here in this situation, how to differentiate meningitis from encephalitis, and what is the empirical choice of antibodies in pyogenic meningitis suspect, pyogenic meningitis, and what is the role of this dexamethasone in pyogenic meningitis, and what could be the dose. So differentiation between meningitis and encephalitis, and empirical choice of antibodies in pyogenic meningitis, and role of DEXA. Can someone unmute and answer? Please try answering. We don't have much time. They asked me to close by 6 o'clock. If it is slow, we need to run fast. So, okay, I'm moving. So the main difference between meningitis and encephalitis is you have meningeal signs in meningitis, and your mental status alteration and the seizures are a little bit uncommon in meningitis, but they're more common in encephalitis. And focal deficits, at the early course of the illness, the focal deficits will be very much rare in meningitis, but it is a hallmark feature in encephalitis. And in meningoencephalitis, it will be midway between them. They can have features of both. So mainly meningitis is caused by bacteria, and your meningoencephalitis or encephalitis can be caused by mostly by viruses. And this is the table, busy table showing what are the common etiologies in the children and recommend empirical therapy. And you can see here, less than 1 month, it's mainly Streptococcus agalactiae and gram-negative bugs. And the children up to 2 years of age, it is mainly Streptococcus pneumoniae and Haemophilus influenza. And Neisseria is very rare in our Indian setup. And other age group like 2 to 16 years, and it is mainly Streptococcus pneumoniae for us. And if you have any circumstances like penetrating trauma or post neurosurgery, you need to suspect Staph aureus and Pseudomonas. And if you already have cerebrospinal fluid shunt like VP shunts, then you have to suspect coagulative staphylococci, Staph aureus, and Pseudomonas. So when you suspect Streptococcus pneumoniae, and the choice of empirical choice is ceftriaxone and vancomycin. Here the vancomycin is not for Staphylococcus cover, it is for Streptococcus cover only. Because it is emerging resistance to ceftriaxone, we don't want to take a risk. So we are adding vancomycin as an add-on agent for Streptococcus, not for Staphylococcus. Another alternative when you suspect resistance for ceftriaxone is to add meropenem. So if you start ceftriaxone and vancomycin blindly for a more than 1 month old child, it will be a safer alternative for any disease, except if you have a circumstance like Staph aureus, Staph aureus, there Pseudomonas, you need to change the ceftriaxone, but vancomycin will be common for all. And when you suspect Pseudomonas, you can try cefepime or meropenem, or you can go for narrow spectrum ceftazidime. And what is the role of steroids? Many of us feel that steroids are mainly
cerebral edema.
Yeah. That is the commonest thinking, but it's not that. In pyogenic meningitis, it is not for reducing cerebral edema. It's mainly to decrease the hearing loss and to prevent certain neurological sequelae. But it's not because the problem in cerebral edema, the cause for cerebral edema in your pyogenic meningitis is multifactorial. It's not only your inflammatory thing. There's so many things for that. So steroids are not proven beneficial in reducing cerebral edema. That's why we are not giving for them. And even in TBI, traumatic brain injury guidelines, they're not recommending steroids for reducing cerebral edema. So the analysis, what they done in subgroup analysis, for Streptococcus pneumoniae meningitis, even steroids can reduce the death rate, and not for other bacteria. And even in hearing loss, it is mainly proven for Haemophilus influenza, not for other bacteria. And the main complications is the recurrence of fever, but it's not major adverse effects. So please remember, your steroids is not for your reducing the mortality by the ICP. It is mainly for hearing loss, significantly lower the rates of hearing loss. So this is a CSF analysis done there. Can anyone interpret this? The total count was elevated. Differential is neutrophil predominance. Protein is elevated. Sugar is low. Gram stain and ARB stain are negative. Straightforward answer.
Bacteria.
Yeah, mostly it's pyogenic meningitis. So this is the different findings in your CSF in different diseases. In pyogenic meningitis, mainly you'll have more cells, predominant neutrophils. you can have a hypoglycemia and protein is elevated. And partially treated meningitis, the cell count will be low, but protein will be elevated only. Glucose can be normal. And aseptic or mainly viral, count can be anywhere between 10 to 1000. And neutrophils can be predominant in some kind of viruses, example mumps, and protein will be less. In tubercular, you can see here cells will be around 5050 to 500. They also can have low glucose, high protein, and but classical teaching is the percentage of neutrophil should be less, 30% or 50%. But in some studies it is proven that in early tubercular meningitis, say less than 1 week, you can have neutrophil predominance as well. So don't rule out tuberculosis by seeing neutrophil predominance in early LPs. If you are in second week or third week LPs, then it's all good. But if you're doing LP in the first week, then you can have neutrophil predominance as well. So don't rule out TB meningitis in this scenario. And fungal, you have low neutrophil predominance and you can glucose level is low. So further course, even despite antibiotics, child has persistent fever spikes and sensorium was okay, accepting feeds well. Because of persistent fever spikes, upgraded antibiotics to meropenem on day 4. Even after upgrading antibiotics, there is no response. So what do you think here in this scenario? Persistent fever spikes.
Complication of meningitis like brain abscess.
Exactly. Anything else apart from complications of meningitis? So complication of meningitis is very good answer. But apart from that, start with routine things. So any infection not getting control, you need to look for whether you're treating
resistant strains.
Whether treating the correct bug with correct antibiotic, or you need to change the antibiotic. Already we don't upgrade the antibiotic, so it is not much resistant support. Most probably, maybe we're targeting a wrong organism, or we are not clearing the focus. Like if you have like abscess somewhere, focus like mastoiditis, somewhere skin abscess was, thigh abscess was there. That's the focus. You can have to identify that focus and have to remove that focus. And the most common scenario here in our hospital settings is thrombophlebitis. So that can be a persistent problem because you're giving so many antibiotics, they can have easily get thrombophlebitis. And the third entity is drug fever. So the antibiotics can cause drug fevers. So we need to think about that as well.
Sir, please unmute.
Raymond, we're not able to hear you.
Yeah, sorry. So in neurological complications, you need to think about subdural effusions and empyema, abscesses, ventriculitis, and CSVT. And it could be a vasculitis leading to symptomatic hemorrhage or hypothalamic dysfunction. So these are the DDs you have to keep when you have persistent fever spikes in a meningitis child despite adequate antibiotics. You need to dose the antibiotics perfectly before you're going to rule out all these conditions. And further course, because of persistent fever spikes, they have done the LP after 1 week, and this is the repeat LP picture. So what is the interpretation from this LP, and what is the roles, actually what is the role and indications for repeat LP? Because nowadays we are not doing commonly repeat LPs. So is there any indications and the role for repeat LP in meningitis? So what is the first of all, the interpretation of this LP? Child is improving, worsening, staying same.
Big improvement in cell counts.
Yeah, it will improve in cell counts, but the protein is rising.
Rising.
And the sugar is falling. So these are two things. One, there is improvement in one area and the worsening in other areas. So we need to take it with a pinch of salt. And what the indication for repeat LP?
Not improving the condition.
Exactly. So the main primary objective for doing repeat LP is to see whether the CSF is getting sterilized. Usually the normal norm is when you give adequate antibiotic therapy, the CSF to get sterile in less than 24 hours. And the other signs are, if cells are there also, you need to see for rising glucose level and falling lactate level. These are the three things which can tell your CSF picture is improving. So indication for repeat LP is clinical failure. In 2 to 3 days is the usual guideline they given. And if the organism is very high risk for treatment failure, if you identify Staphylococcus pneumoniae with cephalosporin resistance, we need to prove that child is improving by doing repeat LP. And the second organism is MRSA. If you have MRSA identified in the CSF, we need to show there is an improvement in the CSF as well, or it is cleared of MRSA. If a culture is positive, CSF culture is positive MRSA, we need to do the repeat culture. So this is not an absolute indication, but these are clear indications given. So CSF was improving, the was improving and continued the same antibiotics. On day 10 of illness, child developed recurrent seizures, needing multiple AEDs to control seizures. Child was loaded already on phenytoin, now they loaded with Leipil and phenobarbital, and child had worsening sensorium, so child was referred to our hospital. So this was on day 10 of illness.
MRI.
So when child was arrived to our ER, this is the child condition, airway is not maintainable. Child had stridor, tachypnea, desaturations and rheumate, and circulation wise, there's a bounding pulses, tachycardia, BP was low. Disability wise, he was a low poor sensorium with decorticate posturing, active posturing was there. Child was febrile here. So this is the primary assessment we done at our ER. So what are the interpretation from this here? Problems, what you are seeing here? So airway is not maintainable. Respiratory wise,
Distress.
distress was there. Circulation wise,
BP low, hypotension.
so decompensated shock. What is the type of shock here?
Decompensated.
Distributive shock.
Distributive shock.
Distributed.
So disability wise, so you have low GCS. So how to intervene here? So you can give airway protective measures again, supplement O2. So you can start IV fluid bolus and you can ask for NARD infusion, and you can try give one midazolam. But the main problem here is the decorticate posturing, and the posturing can be due to your seizure, active ongoing seizure, or it could be due to your CNS damage or raised ACP. So when you have active posturing, don't think only of seizure, think about other things as well. That is like your raised ACP. So there you can try a 3% NS bolus. So because already you know the child was seizing long time, child was referred from the referral hospital. There also child was loaded with Leipil and phenobarbital. So it could be at least more than 1 to 2 hours. So you have to suspect cerebral edema in this child. What are the reasons of worsening in this child? So child was otherwise okay for 10 days, but there is having persistent fever spikes. But all of a sudden, yeah. So it could be probably or complications of meningitis. So it could be your CSVT, it could be vasculitis leading to vasospasm, ischemic stroke, bleed, or it could be your hydrocephalus. You should think about hydrocephalus when you're progressing towards second week.
Ventriculitis.
Yeah, ventriculitis, hydrocephalus, and it could be due to metabolic complications. Hyponatremia, the most common atrial implant is hyponatremia. What is the reason for the hyponatremia and meningitis?
Cerebral salt waste.
That's the first possibility. Second, the most common is not cerebral salt waste. Cerebral salt waste is second common. Most common is
ADA.
SIDH.
SIDH.
Or you can other infectious complications like subdural effusion, empyema, and brain abscess, or ongoing seizure activity. If you have already status epilepticus, even your convulsive status can be controlled, but you can have non-convulsive status. So these are possible reasons for your worsening.
NCS.
Yeah, exactly. So what we did in our hospital, we elected intubated this child because of poor sensorium. As Jesus less than 8, we elected intubated. We continued on 3% infusion. We taken this child immediately for CT scan because we are dealing with the complications of meningitis. We need to rule out hydrocephalus, stroke, bleeds. So we taken for CT brain. We started him on neuroprotective measures, and we need to continue antibiotics because already proven meningitis was there. So we continued on meropenem vancomycin, and we added other AEDs, continued other AEDs as well. What they started there, Leipil, phosphate, and phenobarbital. And because already child is continuous seizures, and we started him on midazolam infusion as well to sedate him as well for your intubation procedure. And we started him on continuous EEG monitoring. After starting EEG monitoring, there is no active epileptic activity. This confirms that there is no non-convulsive status in this child.
And what is the maximum midazolam infusion dose?
It depends on so many guidelines are there. Apart from our Indian guidelines, US guidelines, UK guidelines, all say the different. Indian guidelines 36 mics per kg per minute. US guidelines 32 mics per kg per minute. UK guidelines 16 mics per kg per minute. So it depends on the guideline. So my personal experience in my PG time, I gone up to 32 mics per kg per minute safely. But if now we have a lot of other alternative options like your thiopentone,
Pentobarbital.
ketamine, magnesium sulfate. So we are not going much to on midazolam now because they have a lot of side effects midazolam. Now we are restricting in our unit to 10 mics maximum. If you not respond to 10 mics, then we are moving to the next line.
Thank you, sir.
So what are neuroprotective measures you take in this child?
Euthermia, euglycemia, euvolemia.
Exactly. Anything else? So we'll go step by step. So always when you are dealing something, you need to go in a systematic way. So coming to fluids, you need to maintain normovolemia. If child is hypovolemic shock, you need to replace the fluids.
ఎలా తీయాలి?
Once child become euvolemic, you need to restrict the fluids. The main reason for this is to prevent hyponatremia due to SIDH. And respiratory system, your targets of CO2 and PO2 is normocarbia and normoxemia. And CVS, your target of MAP is a 50th centile. It's not like another shocks, it is a 5th centile. But in CNS conditions, when you have to maintain MAP to improve your cerebral perfusion pressure, it is a 50th centile. And abdomen, mainly you have to consider early feeds. And hematology, if it is unstable, your target HB is 10. And if stable, HB is target 7. In metabolic wise, you need to keep a sodium at higher level. So your target sodium should be at least 145. Even the child is okay, borderline okay, whatever it may be. The CT is not showing cerebridema also. So you can try to maintain sodium at 145 so that we will prevent the fall in sodium. And other should be normal range, and you need to maintain normoglycemia. Sugar should be at between 18 and 150. In CNS wise, you need to continue adequate analgesia and sedation because the brain can precipitate the ICP, and you need to give bolus dose of sedation during suction and IV line insertions. You need to control seizures adequately, and you need to have EEG monitoring when you suspect normal status. And head should be midline and 30 degrees elevation is to drainage your venous return from the brain. And your cluster nursing should be there. You have to cluster all your nursing procedures at a single point of time. And you have to maintain normothermia. You have to be very aggressive with fever. You have to jump and you have to control the fever. Whatever methods you can use. And these are the investigations done in our hospital. HB 7.9. Total count was much elevated with neutrophil predominance. Platelets are very high, 9 lakhs. But CRP is not that much elevated. It's 10. Your electrolytes are okay. Sodium is 139. So already we give you bolus. So we are continuing the infusion. And LFT was normal. So all these things suggest to have some infection, bacterial infection. So this is a CT brain. Can anyone read the CT brain? Is there any signs of cerebral edema in this CT?
Yes, sir.
Where? Can you point out where it is?
Ray-White matter differentiation is
You cannot differentiate that with your image provided here. Leave that alone. Look for other common. First, what is the earliest sign?
Fourth ventricle.
So it is this apple sign. You need to see the fluid surrounding this apple. So here, my arrow mark is visible here.
Yes, sir.
Yeah, see here, this is the apple. So you can see here also. So that is what you have to look for first thing, and your Sylvian fissure. This is Sylvian fissure. So that will be lost when you have this. There is the earliest signs of your pressure ACP. If you lost this fluid around this apple, and your Sylvian fissure is lost, then it is the early signs of pressure ACP. And next signs you can have is your ventricle compression, decrease side of ventricles, and loss of Ray-White differentiation. And the severe cerebral edema, you don't see ventricles at all. They're compressed like slit-like ventricles. And this is the CT of same child. And the down picture also. Now can you tell? So what is the abnormality we are seeing here?
Enlargement of lateral horns.
Exactly. So that's an enlargement of ventricles. So this is a sign of developing hydrocephalus. So it's a complication of your meningitis. So further course, we added estrogen to decrease CS of production, and we control the seizures, and we wean and stop at midazolam, and shock was improved, so we stop at noradrenaline. sensor was slightly improving, and we did the fundus. There is normal. So we go ahead and done the LP in this child. So we just want to do the main LP. Why we did here is to identify the organism. So we want an organism because child is not improving and child is developing hydrocephalus. So we want to identify the organism here. So for that reason, we did the LP, and the opening press was very high, and the analysis was this. So there's a decrease in total count, but still it's neutrophil predominant. It's a rising protein. So what is the reason for rising protein? Here could be your hydrocephalus, and still your hypoglycemia is persistent. Your Gram-Stein AFB stain is negative. So what we all feel, child might be improving and your infection wise.
Partially treated.
Yeah. But the main problem
Yes,
here
sir.
is sugars are not rising. Even if our treatment cells are counting decreasing, your sugars are not rising. So we continue the same
Yes, sir.
antibiotics. We stop with the phenobarbital and our CSF panel. Usually we send CSF panel for a meningoencephalitis panel. It contains a virus, 6 to 7 viruses, 4 to 5 bacteria, including TB. So in that we got positive for Mycobacterium tuberculosis. See here. So for last 3 CSF, everything is pointing towards pyogenic meningitis, but the picture turned now towards TB. So that's why when your drugs are not working properly, you need to think for alternative diagnosis, alternative organism as well. So always make a habit of sending PCR, at least gene expert. So now the plan is to start 4-drug ATT along with the steroids, and CSF and blood cultures came sterile. We stopped.
Sir, one doubt.
Yeah.
Sir, is it mandatory to send HIV in these patients, sir?
H. No, I'm not able to get your question. H.
HIV, sir, before starting ATT and steroid.
Definitely. Yeah. My hospital protocol is only ICU admission. We'll just totally do the screenings. So I have not mentioned here. Entire guidelines of TB guidelines dependent on your underlying HIV stage, your underlying HIV status and your drug resistance. So that will move on to the treatment guidelines. You see there. And definitely you need to consider checking HIV status before starting ATT. Your ATT panel, drug panel should be modified according to ART.
Yes.
So further course here, as child sensor is not improving, we repeat the CT. As initial CT is not showing mild enlargement, so repeat showing worsening hydrocephalus. So we take a neurosurgeon consultation, went ahead for BP shunt, and post BP shunt, gradually child sensor improved and child was extubated on day 9 of admission here. So post that, child sensor gradually getting better, able to take oral feeds, the counts and CRP normalized. But on examination, child had increased total reflexes, and we initiated child on lymph physiotherapy, neurorehabilitative measures. And at discharge, child was not recognizing parents. He is not able to sit without support also, but he tolerated ATT well, taking oral feeds. So we discharged the child on our ATT, 4-drug ATT, and prednisolone and pyridoxine, and anti-epileptics, levuculin and ferritin. So these are the things child was discharged. So while we move on to discussion about ATT, this is the most important thing we need to discuss. So what are the current guidelines on treatment of ATT for TB meningitis? So what is the role of steroids in TBM and what is the dose? What is the role of pyridoxine in ATT? And what are the complications of ATT drugs? And what are you going to monitor while on ATT? These are the 5 important questions we need to discuss when you start to talk about ATT. So what are the current guidelines ATT? What are the drugs? How many phases of therapy you have to give? Yeah, please answer. This common question of ATT we're going to do
9 months.
So what are the drugs? Tell me first what are the drugs?
HR.
It is HRZD. So what are the, how many phases are there treatment?
3 months plus 6 months. 9 months total of 9.
Phases.
12 months. Total course is 12 months.
Yeah, 2 phases are there. Your intensive phase and your continuation and consolidation phase. So it is 2 plus 10. So no recommendation is 2 plus 10 for HRZD and your 10 HRE. This is what Indian guidelines recommendation, and it's the latest recommendation by your ICMR standard treatment flow guidelines, which was released in 2022 March. See here, it is a 2 HRZD plus 10 HRE, and your pyridoxine dose is 10 mg per kg, 10 mg per day. It's mainly given to prevent the peripheral neuropathy caused by your isoniazid. And the steroids are indicated in ATT meningitis. There's a dose is 2 mg per kg per day for 4 weeks, and it will taper over next 4 weeks. And the recent recommendation by WHO, when you have severe diseases, you can go up to 4 mg per kg per day with a maximum of 60 mg per day. So and you can also try dexamethasone, and it will not give you oral prednisolone in equivalent doses. And these are recent recommendations from WHO. So this is released in recent 2022 April. So these are the guidelines. Apart from your routine Indian guidelines, what are changes here? Just I'm going to highlight what are changes here. So they have modified the total duration as well. See here, for non-severe pulmonary tuberculosis, when the age group of the child is 3 months to 12 years, you can go for 2+2 regimen. 2 months of intensive phase and 2 months of continuation phase. Instead of 6 months, for non-severe TB, you can go for 4 months. And they have proven evidence for this in studies. And even they are removing ethambutol in the intensive phase and also in the continuation phase. Now in continuation phase, they completely removed ethambutol. They totally removed of ethambutol. And intensive phase also, they ask you to remove ethambutol if you have less prevalence of HIV in your region and your isoniazid resistance is very low and you don't have severe disease. So these are the 3 indications to give ethambutol. One is your HIV prevalence is high, isoniazid resistance is high, and severe disease. If you don't have these 3, you can stop giving ethambutol in the intensive phase also. But in continuation phase, they're taken off ethambutol. This is the recent 2022 guidelines released in the March. And even they given one more alternative regimen containing rifampicin and moxifloxacin. These are the 4-month regimen, 2+2 regimen. Here you will have isoniazid and pyrazinamide along with rifampicin and your moxifloxacin. And in continuation phase, you remove the rifampicin, just you do pyrazinamide and continue as 3. You can easily get it from the WHO website. It's there. And in TB meningitis, it is 2 HRZD plus 10 HR. There is no change in this. And there is additional recommendation, conditional recommendation you can try is 6 months course of HRZ ETO. ETO is ethionamide. So instead of ethambutol, if you use ethionamide, you can finish the course in 6 months itself. This is a recent recommendation, and they showed it's equally efficacious. It's non-inferior to the standard recommendation. These are recent changes. So coming to the doses, you need to give daily doses. There's no 3-weekly, thrice-weekly regimen now. This is standard recommendation became. So you need to go for the highest doses possible in children. Younger the children, you need to go for the higher side of the dose. And older the children, you have to come to the lower side of the dose. The range is 7 to 15 like this. And if you are choosing for 6 months regimen, it is the dose for ethionamide. And all other doses also been higher side. Isoniazid, rifampicin, and pyrazinamide, you have to go up on the standard dose. That's the main difference in the 6-month doses. And what are the common side effects? Your hepatotoxicity, mainly by isoniazid, rifampicin, and your pyrazinamide. And peripheral neuropathy, linezolid and isoniazid. And electrolyte imbalance, your streptomycin. And visual toxicity, your ethambutol and linezolid. So these are the main side effects when you're giving ATT. You have to look for all these side effects. Mainly hepatotoxicity, peripheral neuropathy, visual toxicity. And what are the things you have to monitor? You need to monitor complete blood counts, electrolytes, RFT, LFT from baseline and monthly after that. And you should do eye examination every monthly. And if you have meningitis, you need to look for neuro examination, ideally weekly. And like other things like electrocardiogram and use other drugs. For routine drugs, HRZD, CBC, your electrolytes, RFT, LFT, and eye examination is must. Monthly basis.
Revant, you have 15 minutes remaining.
Okay. So first follow-up, child sensor was gradually improving, 12 months gradually normalizing. And second follow-up, we did at 4 weeks of discharge. Child was able to sit without support, able to stand and walk with support. And he's recommending parents now. And LFT we did at this point of time. It was a little bit elevated, but it's not constitutes to your hepatitis. So we continued on the same regimen.
ఈవినింగ్ రమ్మన్నారు కదా తీసుకోలేదు అది మీరు వస్తే
And fundus was normal. So child was brought with the complaints of nausea and vomitings, and there's a decreased appetite as well. And what are the DDs we have to consider at this point of time, and what is the workup we have to plan here? So complaints of nausea, vomitings, and decreased appetite.
Could be due to ATT, sir.
Yeah.
Workup is we need to have repeat an LFT, and if there is increased bilirubin or transaminitis, I think we have to modify the regimen, sir.
Exactly, 100% correct. Apart from routine gastritis, what you have to consider in this child, if the same child, if this complaints, if some child comes to you, the first thing you have to think is some gastritis point only. But in this child already in ATT, we need to think beyond that. So this is the LFT. What is the LFT? So LFT grossly elevated, CPT is elevated, bilirubin is normal, and your PT diabetes is normal. So what we have to do now? As the previous.
Stop the drugs causing transaminitis.
What drugs you have to stop here? What are the drugs you have to stop here?
Isoniazid and rifampicin, sir.
That alone? One more
First,
drug
we have to ethambutol, sir.
pyrazinamide. So ethambutol will not cause hepatotox.
Yeah, okay, sir.
So we stop it now. Can we just leave the child on ethambutol or need to modify anything here? Because child is having meningitis, now only child is improving. There's an active TB, life-threatening TB. Whether we can simply stop the 3 drugs and leave the child like that, or we need to change modify the ATT.
Add
Streptomycin, sir.
So we need to modify ATT. So what are the drugs you need to modify here? Already taken on 3 drugs. What 3 other drugs you have to add here?
Is it streptomycin, sir?
Streptomycin,
Yeah, exactly. Streptomycin we can add.
linezolid,
Yeah, linezolid. Before that,
quinolones, sir.
quinolones. Don't
Chloroquinolones.
forget about quinolones. Quinolones are the best agents, where your sinus penetrability is much better than other drugs. Good. So this is a drug-induced liver injury. So the criteria for that is, if you have any symptoms, your enzyme should be elevated by 3 times, and your bilirubin should be more than 2 times. And if you don't have any symptoms, your enzyme should be elevated by 5 times. So then only you can tell it as drug-induced liver injury. So meanwhile, you need to rule out viral hepatitis, and you need to look for other things, ultrasound liver as well. And as I was told, you need to stop the ATT, you need to modify the ATT. So that is what we need to see here. So what are the principle when reintroducing the ATT? So you have to reintroduce only ATT when you have enzymes less than 2 times upper normal limit, and you need to start 1 drug at a time. You don't start all the 3 drugs at a time. Start 1 drug at a time. It helps you identify the culprit. And the duration of ATT you have to modify when you have started the full ATT again. When you come back to the 4 drug ATT. And symptoms recurs once you started the ATT, you have to stop the last drug. And if you have cholestasis, think about rifampicin. And if your ATT hepatitis is very severe and it's life-threatening, and coagulopathy is also there, then you no need to restart pyrazinamide. And if you don't start pyrazinamide, you have to extend your therapy for 9 months when you are doing for pulmonary TB. Like for 6 months, you can increase to 9 months. For TB meningitis, you can extend further depending on response. So the references for this is your ICMR guidelines and WHO guidelines. So this is the protocol for reintroduction of your ATT again. So one arm is sequential reintroduction, where you can straight away start the full dose of the drug and repeat LFT after 1 week and introduce the second drug, third drug, like that. And second thing is incremental. So this is the one we will follow. You start at a lower dose, rifampicin, starting as 10 mg per kg. You can start at 5 mg per kg. After 3 days, you can increase to 10 mg per kg and repeat the LFT after 1 week. So like that, you can increment the dose. This is the safest one, what we follow routinely. So in this child, it's a delay confirmed. So we stop out the HRZ, added levoflox, linezolid, streptomycin. And we repeated LFT weekly, and it was normalized in after 2 weeks. And then we restarted rifampicin, in isoniazid and pyrazinamide incremental basis. And once we add one drug, we start tapering the other drug. So in the sequence of streptomycin, linezolid, levofloxacin. I think I'm clear on this. So once you start adding one drug, you can start tapering the other drug. What we added for the replacement. Meanwhile, you have to check the LFTs. Don't forget about checking LFTs. So after starting the full drug regimen, again child had worsening of LFT. So what we have to do now? So we reach it to HRZD again. After that, LFT was worsening. So what is the culprit here?
Last restarted drugs.
Yes. So the culprit is pyrazinamide. We have to stop the pyrazinamide.
Stop.
So we stopped pyrazinamide. We added levofloxacin for this child. So after 1 week, we see LFT was normalized. So meanwhile, neurological child was normalized. So after 4 months of ATT, child was brought to us again with the complaints of he was not able to stand and walk for the past 1 week. And he also has multiple non-bilious vomitings for the past 2 days. And he's applied as dropout, not taking feed well. But there is no fever. So LFT is improved, normalized. Neurologically, child was absolutely normal. And again, we have seen this. Child was not able to walk and stand. And there's vomitings. On examination, yeah, we'll go towards. So his tone was normal to decrease in the lower limbs, was normal in the upper limbs. Power was reduced in the lower limbs. And DTRs was exaggerated in the knee and other upper limbs, but ankle was absent. And there's a bilateral plantars, there's extensors, and your superficial is exaggerated, and sensations was normal. So with this history and examination findings, what all things you have to consider here? It's very important. So we will hold this slide for a few minutes. So everyone has to think and answer here. So you have a TB meningitis patient having drug-induced hepatitis, which was modified with ATT, which was improved with modified ATT, and sensorium and neurological child improved much better. And again, after 4 months of ATT, child had not able to walk and stand. And this is the examination findings. So what all things you have to suspect here? Come on, few DDs at least you can answer. The main culprit here is brain or spine. At least we can divide into that. Whether it's UMN or LMN, or it's a brain or spine. So we can divide like that, we can answer. So mostly everyone is feeling a spine because sensorium is normal and there is a problem with your power and tone and reflexes. Most likely, yeah, someone answers spot spine. Absolutely correct answer. So we need to think of spot spine also. But the problem here is there's mixed findings of LMN and UMN here. So LMN findings are absent reflex, absent your ankle reflex and decreased tone. And your UMN findings are exaggerated reflexes and bilateral extensor plantars. So we'll move on to and see what are the DDs we can kept here. So one is worsening hydrocephalus because there is other vomitings. So we need to think of worsening hydrocephalus as well. And the second most common DD we have to keep is tuberculous radiculomyelitis. This is the commonest entity when you're having spinal involvement, apart from your brain. And third thing is your drug-induced peripheral neuropathy because your absent reflexes are there. You need to think about this. And spinal complications, spinal tuberculoma, myelitis, rhingomylia, and your vertebral TB compressing the spinal cord. And the last thing is electrolyte imbalance because the child was on streptomycin previously. So we need to think about electrolyte imbalance of hypokalemia as well in this state. So what's the workup we have to plan here? Workup. So these are the DDs we kept. And what the workup?
MRI spine, sir.
Before that, easily done. First DD.
Head circumference monitoring, sir.
Because this is 1.5 hour child, you cannot monitor head circumference.
That McEwen sign. Watson.
Clinically, it's not possible because this already BP shunt was there. So we can go for CT brain. And the second thing is you need to look for MRI spine to rule out your tuberculous radiculomyelitis. And third thing is one by one, you have to go for one by one. So we'll see here, we done CT brain, it was same, and shunt was in situ. And we did MRI brain with spine with contrast because there's some findings which was also human lesion as well. It was absolutely normal. With contrast we did because without contrast it's best to do MRI spine when you're suspecting radiculomyelitis. And we did nerve condition studies as well because one of the DD we kept is drug-induced peripheral neuropathy. It was also found to be normal. And we did electrolytes, it was normal, no hypokalemia. So at this point of view, so what is your probable cause and how will manage?
Revant, last 5 minutes.
Yeah, last 2-3 slides. So CT brain normal, MRI brain with spine contrast normal, nerve condition studies normal, electrolytes normal. It's So it's a dilemma for us as well. So because MRI spine and ankle was normal with absent ankle reflexes, and even though NCS was normal, it's strongly suspected drug-induced peripheral neuropathy. So for that reason, I have stopped isoniazid and I increased the dose of pyridoxine to 40 mg per day. And I went to the literature. The literature is the case report which was published in WHO journal. This case report was exactly similar to our child. So this is an older adult only. This is not a child. The adult, which is same findings with multiple human and element signs are there. So they also suspected this drug-induced motor neuropathy. And finally, with the pyridoxine and stopping isoniazid, the adult improved. So we'll now move on to our child. And by stopping isoniazid, we need to modify the ATT again. So how to modify? And whether you have to go for intensive phase or continuous phase, or continue both. And before going to this phase, we need to have 3 points in your mind: that the disease is still active, or disease activity is decreased, or how much course is finished till now, and what are the drugs which can penetrate CNS. These are 3 important questions we need to ask when you're modifying your ATT. So one is the activity of the disease, course till now finished, and CNS penetrate the drugs. So this is the chart showing what is the drugs which are good penetrability. So in this you can see fluoroquinolones are the best drugs, and your ethanolamide and cycloserine are the good penetrability drugs, and your lenalidomide. These are the 4 good drugs for penetrability. And if you have high dose isoniazid, pyrazinamide, it's a moderate penetrability. And you come to see ethambutol, it's very negligible, and your streptomycins are the negligible. And rifampicin, so many studies have shown it's poor, and few recent studies have shown it's moderate penetrability. So see our HRZD, our routine HRZD, only our 2 drugs are having good penetrability, moderate penetrability. Rest of the other 2 drugs, HRZD has very poor penetrability. But because of these 2 drugs are there, we are continuing that. And ethambutol mainly adding because to reduce the source from other, not from the meninges, from the other parts of the body. So fluoroquinolones, ethanolamide, cycloserine are the best drugs, and lenalidomide, apart from the routine ATT. So in this child, MRI is not showing any active TB, and child is already finished. You are for 6 weeks of 4 HRZD, and almost 10 weeks of modified ATT. Almost like 4 months was over. And considering CNS penetrability, ethambutol and rifampicin is very poor. So we decided to add levofloxacin, cycloserine for this child. And here we see ethanolamide and lenalidomide has good penetrability. Why we have not chosen that ethanolamide and lenalidomide for this child? We choose a levofloxacin, cycloserine instead of ethanolamide and lenalidomide. Can anyone answer?
Second line ATT.
See here, ethanolamide has hepatotoxicity again. So this child already fails lot of problems with hepatotoxicity. You don't want to trouble the child again. And lenalidomide can cause peripheral neuropathy. You are already treating peripheral neuropathy. You don't want to worsen it again. And your visual toxicity also, ethanolamide is there. So already ethambutol was there. So we don't want to make the visual toxicity worsen. So these are the things we need to keep in mind when you're modifying your ATT. So what is the penetrability of CNS and what are the complications? You should not combine the complications, drugs having same complications. So after 2 weeks of follow-up, child was walking without support, LFTs are normal, upright improved, child was doing good, and we decided to continue same drugs for the next 10 months. So I rest my case here and we'll move on to take home messages. So you have to suspect TB in all meningitis when there is no improvement, even if CSF pictures are pyogeny, and try to do a routine viral and bacterial PCR. So we do it in a microbiological laboratory. It costs around 2,600 rupees only. Maximum is 3,000. So we'll get some 7 viruses and 4 bacteria, including TB. So it's a very cheaper option. Even in government hospitals, I think we can promote. We can ask the parents to go for this. And at least you can try GeneXpert. If you are resistant pyogenic meningitis, you can try to get GeneXpert. And first of all, you know your complications of ATT and you try to monitor for them. And drug-induced liver injury is a common entity. Screen for it. Don't forget about it. And peripheral neuropathy can be seen as an agent, and it has resolved completely by stopping the drugs and with pyridoxine. And most importantly, ATT, this ATT guidelines keep on changing from year to year. So we need to cope up with the recent advances. So don't stay on the old guidelines. We need to move on to the new guidelines. So with this, I'll finish my presentation. I can happy to take some questions.
Thank you, Revant. That was actually a wonderful talk. You have cleared so many doubts for us. So I was also thinking like different various presentations of TB meningitis. So how we can miss the initial presentation or initial workup, and what is the importance of doing repeated LP, which usually most of the units not to do that, and followed by again when we start on ATT, what to exactly monitor, what are the different complications which can arise. You have cleared all of the doubts. It was a wonderful discussion, and there was active participation among the PGs also. That's really nice to have. And last take-home message was very important because in our unit we do this meningoencephalitis panel, and there were few questions asked why we do that. It will help the causative organisms. For this case also, we don't know the causative organisms, and he had a doubt. So if it is Streptococcus pneumonia, then definitely if you don't add Vanco, there is a resistance among the ceftriaxone. That is the reason we do this. And if you're suspecting even any viruses, or sometimes you're thinking child is not improving, you add acyclovir and you don't want to continue acyclovir. So HSV also will be known in this. And even GeneXpert also is very, very helpful. So that is the importance, and it is very less cost only. It is cost hardly 2,600 to 3,000 rupees. It will really help a lot. And thank you once again, Revant. Thank you so much.
Thank you, Bhaiya. If there is no doubts, I think we can conclude this session. You can post in the group as well. If any doubts you don't want to ask here, you don't have time constraints, you can try to put the questions in the WhatsApp group. We'll try to answer a few of them. And we have a lot of experts in the group as well, so they can also contribute for the discussion. Can we?
Bala,
Yes, sir.
anything else in our completed, no?
Yes, sir. Thank you once again. So that's a overwhelming response from all the postgraduates in this Zoom session. And we are conducting it once in fortnight. So next session will be after exactly 2 weeks. And we'll send you the link. And thank you once again, Dr. Revant. And thank you, Andhra Hospitals team. Thank you, sir. And I will conclude this meeting. Thank you so much.
Okay, thank you. Thank you all.